Hello, everybody. Good morning to you. Good afternoon to our relatives here on Canada side, and I know it's breakfast and lunchtime for you over in Australia and New Zealand. So I'll start off. Hello, everybody, and welcome to Pathways to Truth and Reconciliation in Organ Donation and Transplantation, Café Scientifique. My name's Craig Settee. I am a living kidney donor. My experience has been in central Canada, in the prairies, where I am originally from. Winnipeg, Manitoba is where I was born and raised, and I'm a Cree citizen of Fisher River Cree Nation, and my family comes from some other areas around Lake Winnipeg in Manitoba. And I now live on the west coast of Canada in what's called Vancouver, British Columbia, but it's also home to the Coast Salish peoples here in this territory. In the area of Vancouver, specifically the Squamish, Tsleil-Waututh, and Musqueam First Nations and peoples of this territory. So I just wanted to start off by opening up our session in that way, and just also to thank everyone for coming to participate today and for joining Cafes Scientifique, which is led by Dr. Caroline Tate and co-hosted by the First Nations and Métis Organ Donation and Transplantation Network, as well as the Canadian Donation and Transplantation Research Network's Indigenous platform. And it's also supported by the Canadian Institutes for Health Research, the University of Calgary, and the Union of British Columbia Indian Chiefs. It's now my pleasure to introduce you to Dr. Caroline Tate. Caroline is Métis from McDowell, Saskatchewan, which is the neighboring province to where I'm from in Manitoba. She's trained as a medical anthropologist with the research interests in addressing Indigenous health inequities and advancing social justice. Her area of expertise is in health and wellness of Indigenous people in what's now called Canada. Within organ donation and transplant, Caroline focuses on health inequities experienced by Indigenous peoples that contribute to end-stage organ failure. She is a professor at the University of Calgary's Faculty of Social Work. And I'll turn it over to you now, Caroline, to share a few words about today's event.
Yeah. Hello, everyone. I look frazzled because I've been trying to do travel expenses. And the question is how can that be the most difficult thing of my job? So I've been pulling my hair out for 2 hours and I didn't tab over. So apparently I'm such a dum-dum that I didn't tab over. So it's very embarrassing that was my problem. But it's so good to see all of you, and I see we have more people joining in. We had a wonderful session today around, it was over 100 people joining us from across Canada. And we had Chief Philip, who is a double transplant recipient, who's the head of the British Columbia Chiefs, and Celia DeChambeau from Northern Saskatchewan, where I usually am. I'm in Calgary today, but she's from Northern Saskatchewan. And Celia gave us just an incredibly, both of them gave us very powerful presentations, as well as presentations from Dr. Jeg Gill, who's a transplant surgeon. And so we had a really good day earlier on. And I'm so happy that you're joining us. So yeah, so it's just this network that we're trying to build internationally. I really am looking forward to hearing what you have to say. But before we do that, I think Terry Gardner. Terry, are you there? I've been looking for. I'm afraid that our elder might be in the wrong link. And so I actually will try to get her onto, we lost the chief this morning too, so we've had some tech problems, but we'll work towards getting Terry on the right link as well. But I think we can probably just move into the presentations. But one of the things, I guess, before we move in is that the action item that came out of today was a resolution that we plan to draft. It's a resolution that would be the First Nations, Chief Phillips would put forward through the British Columbia Chiefs. And also I would take it to the Métis Nation, my people, I would take it to the Métis National Council and have the resolution. But one of the things I think that we can talk about in time is maybe an international resolution as well. So that in international contexts, and we've talked about this a little bit before with this group of some type of resolution or something to motivate international circles to include more focus on Indigenous peoples globally and the challenges. So Craig, but again, once again, I just want to thank you so much for taking the time, and we have a smaller group now just because it's later in the day, and it's about -100 here. It's really cold, and so in lots of parts of the country, I know that people are probably making their way home because for dinner and that. So we are a smaller group, but I see we have Aviva and Mike and Lori, and so I think I've seen Patricia. Yeah, so we have some of our key people across the country that are here as well. So Craig, I'll turn it over to you.
Sure, thank you. Yeah, so as Caroline stated, we hosted part 1 of this morning's cafe, focusing on Canadian context, and our focus this afternoon in Canada and this morning and afternoon for you in Australia and New Zealand is one of the main activities is the development of an international Indigenous ODT consortium, which is comprised of members from Australia, Canada, New Zealand, and the United States. As a consortium, the plan is to work together to identify common systemic barriers impacting Indigenous patients across to pre- and post-organ donation and transplantation services, and more, just as important, work and learn from one another. Across Canada, Australia, and New Zealand, Indigenous people experience substantially worse health outcomes than non-Indigenous people. The prevalence of chronic disease among Indigenous people has risen dramatically. Indigenous people experience more than twice the prevalence of end-stage kidney disease, and Indigenous patients also have unequal access to diagnostic and therapeutic procedures that are used to treat chronic diseases. Today, we're fortunate to have representatives from Australia and New Zealand to share their experiences, and I'll introduce each of you shortly. But I also wanted to say that we also have a lot of strength in our communities. We do have a lot of people that practice our ceremonies, practice our own traditional ways of healing and wellness, and that's also a really important and foundational part of our health as Indigenous nations, as First Nations, as Métis nations, as Inuit nations, and as relative nations from all over Indigenous country around the world. So I just wanted to also start off by saying that. And so without further ado, I'll share the biographies that I have of Janet and Kelly, and Kim. And Kim is here too. Yeah. So Janet Kelly is a nurse researcher and course coordinator focused on improving healthcare and outcomes with and for Aboriginal and Torres Strait Islander people. She co-designs flexible and adaptable health journey mapping tools that identify barriers and enablers, gaps, strategies to improve care. These tools are increasingly being used for quality improvement, reflective practice, education and training in renal care, cardiac care, nursing, midwifery, and medicine. Janet co-leads AKction 2, a 5-year NHMRC Ideas grant with Dr. Kim O'Donnell. The project brings together Aboriginal Torres Strait Islander kidney patients and their families, health professionals, academics, researchers, and other key stakeholders to identify strengths and gaps to improve care. This collaborative work positions First Nations people with lived experience in kidney disease as patient experts and chief investigators and has 4 nested sub-studies: Indigenous governance, peer support, kidney journey mapping, and cultural safety. I'll say welcome to Janet, and I'll read off Kelli, your biography as well. Kelli Owen is Karuna, Narunga, and Naringajeri. You'll have to help me with the pronunciation after. Is a Naringajeri sovereign woman. She is the National Community Engagement Coordinator for the National Indigenous Kidney Transplantation Task Force, a project officer with SA Health overseeing the Kangwaldi renal project with the Central Northern Adelaide Renal and Transplantation Services, and a chief investigator and member of AKction with the University of Adelaide, and newly appointed member of the Organ Transplant Authority Advisory Committee, and is leading South Australian Health Medical Research Institute Project Compass. She's collaborating with renal teams to adapt health education resources to increase health literacy, to meet the needs of people. In her current role, she works with Aboriginal and Torres Strait Islander communities across Australia, focusing on their kidney journeys, local issues, and culturally appropriate solutions to increase equity and access to kidney transplantation. Kelli is familiar with Indigenous governance and data sovereignty methods, harnessing the voices of Indigenous people to raise awareness of equity issues and the health system barriers to address. Kelli has lived with CKD, knowing end-stage kidney disease would eventuate. Her lived experience of the journey from diagnosis, pre-dialysis, peritoneal dialysis, hemodialysis, transplant workup and assessment, transplantation leading to her current situation of post-transplant care management makes her an invaluable contributor. And lastly, I have a bio for Kim here as well. And so Kim, Dr. Kim O'Donnell is a senior researcher in Aboriginal healthcare at Adelaide Nursing School at the University of Adelaide. Kim is a public health researcher with extensive understanding and experience with Australia's First Peoples in education, health, and governance. Kim is passionate about the development of equitable partnerships between Aboriginal and Torres Strait Islander people and corporate organizations to improve the health and well-being of Australia's First Peoples. And then I know that Dr. Bateman was also planning to join us, but I just wanted to acknowledge that she was going to join us, was unable to today. So with those introductions, maybe I'll pass it over to Janet and Kelli and Kim to start off your presentations.
Thank you very much, Craig. Yes, Sam's doing clinic in one of our remote areas. So she's a visiting nephrologist today. So that's why Sam's not able to join us. She's got a clinic of many people.
Right.
And Kim is on, but Kim's become unwell, so she may or may not be able to join. So I'll be talking on behalf of Kim and I today because she's coughing.
Great.
Okay, so I'll share my screen now, screen share, and it should be this one. Now, does that come up as full screen?
Yeah, it looks good.
Okay, so I'll be talking about the AKction project that was mentioned there in the bios. But first of all, I'd like to acknowledge that we're meeting here today on the lands of the Kaurna people, and also pay my respects to all First Nations people that are here with us today, and also on the webinar that we're doing today. Just working out how to do my next slides. There we go. Yeah. So we'd also like to pay respect to the spiritual and physical connections that everybody has to the land, seas and waterways. And as Craig was saying, really recognising the strength of cultural connection and cultural practices. We would also like to let people know that this presentation will include photos, and we're going to show a short video. So it also shows the video and spoken words of people who have passed, but their families, they and their families have given us permission and also encouragement for us to share this information and to really honour their work as kidney warriors and keep continuing that work. So this is the AKction project. In some ways, we're sort of going back a step. So Kelli will be sharing a lot of what's happening around kidney transplantation, specifically in Australia, and some of the projects focusing on improving First Nations access to and experiences of kidney transplantation. And the work of AKction is kind of the work that we did first. So I'm showing that it's continuing and the two are intertwined. As you will see, there'll be parts that we'll both touch on, and you can see how we're very much working collaboratively in the two projects. As Craig mentioned, it's a space where we bring together First Nations people, Aboriginal and Torres Strait Islander people with lived experience of kidney disease, and health professionals working with them. And so we create spaces where we get to have different conversations, to do research that's really embedded in the priorities of kidney warriors, of people living with kidney disease, trying to navigate the health systems, and very much being led by what the priority should be, what we need to do, and how we can improve the health systems. We would in particular like to acknowledge Inawinchi and Nari, who are two matriarchs who have really led the work that we're doing. Unfortunately, Inawinchi and Nari are no longer with us, and we really honour the work that they have done.
We miss them.
Yeah, we miss them terribly. Yeah, we often just have a moment now where we remember all the kidney warriors who aren't with us anymore. So we might do that for a moment, because yes. So they're with us always. So talking about AKction, so we've done two different phases of AKction. We did AKction 1, which was a small project that we did for a couple of years, and COVID intervened, so it stretched out a bit longer, where we had a small piece of funding, and it was mainly the health professionals coming together and myself as a nurse who was I didn't work clinically in renal, but I've certainly been working a lot with communities around how to improve their health journeys, and renal kept coming up all the time. So that became a focus. And meanwhile, Nari and Ina were having lots of conversations about what was happening for community, trying to access healthcare, community members living in Adelaide, community members coming in from rural and remote, and how could we improve things? So that all came together for AKction 1. So we did community consultations, we started mapping journeys, we did key stakeholder workshops, we did a lot of networking with people in the other states and territories in Australia, and we started working with the new national clinical guidelines that were being written around, it was the first time in Australia and New Zealand that there were guidelines around how could we care better for Aboriginal and Torres Strait Islander and Maori people with kidney disease, and there hadn't been any specific guidelines, so we got involved with that. Then what happened between AKction 1 and AKction 2 is that we changed so that it was less led by the mainly white researchers and kidney health staff, and led much more by community. So then those 4 sub-studies that Craig mentioned, the Indigenous governance, the kidney journey mapping, peer support, supporting for each other, and cultural safety in kidney care. We're very much, the methods we use, we're bringing together Indigenous methodologies as well as Western ways of understanding research, and bringing the two together and working in these brave spaces, trying to decolonise the research and decolonise the health service and the university all at the same time. That's very interesting. Our end goals are very real. We seriously want to take action. We're not here just to do a piece of research. So it's very much about how to improve care for and with people, how to embed cultural safety within our systems and get a stronger Indigenous workforce, better supported in the positions that they're in, and really improving coordination in the health services and systems. And, ultimate aim is that people can have much better access, much better experiences and outcomes of care. This is an example of one of our community consultations, and we love sharing this photo because at the front is Roxanne Sambo, who was an Aboriginal health practitioner. She was a renal specific position. And we were talking about, we're talking with community about, okay, if we set up this action project, what's important? And also, this was informing the national clinical guidelines. So we were going to rural and remote places as well as the city places, and informing these guidelines. So there's Roxanne. She has family connections to the place that we're at in Port Augusta. So she knew people and she could also speak first language as well as English. You can see lying down on the table is actually a dialysis machine that has been painted up. So it's got, Inez started to paint her journey story on there, and she's there with her nieces. Standing up with the phone is the nephrologist. She's taking photos and listening. Tucked right in the back corner is actually the CEO of Kidney Health Australia, and he's listening. And that was really important, that this is the essence of what we've been doing. You know, we need to be able to hear what people are saying, and, you know, other people are needing to listen. And then that's Tali, who's part of our team, one of the nurses who's doing research with us, videoing as well. So very much our project recognises that what often happens in health services and in research is it's often top down, bottom up, and community just feel like they're not being heard, their viewpoints aren't being prioritised. So our project sits in the middle, and we're trying to level that playing field where people can come together. There's a willingness of the health service, and there is. There's been some real traction happening, particularly in South Australia, but in Australia as well. And then community members are engaging with the research, which is a big ask when research has been so untrustworthy for so many years in colonised Australia, you know, to come together there. That's the essence of what we do. Oh, sorry, we just need to wave our arms around. We have, you know, those electricity things. And then, of course, we have the equity lens. How do we ensure that community members can be actively involved? And that might mean we need to put more resources in and more time to ensure community have a voice. So that's the other thing we do a lot. The 4 areas we've talked about, those 4 priorities are all based on things that community raise. Indigenous governance, people kept saying, you know, community members, we are more than our disease. That repeatedly, that's the message. The reference team members know what it's like, and chief investigators really want to be involved. Now, did I mention that in action too? Instead of being reference group members, community members like Kelli and Nari and Rani are chief investigators of the major research grant, rather than only being positioned as reference group members, now being positioned as both, and really central. The journey mapping, people are experiencing journeys that they really hope no one else will have to experience, and so they're sharing them so that we can find out the gaps and the strengths and look at how we can improve them. And cultural safety, sometimes health professionals just don't get it, so we're trying to work with that and improve it. So here's the team that started in Action 1. Do you have anything you want to say about that? We've got a number of these people aren't with us anymore. Beautiful people. Then the peer support, doing a range of different things, teaming up with Kidney Health Australia. Then on the bottom right, there's a picture when we all came together with the Northern Territory group, and that really led to a lot of the work that you're doing now, Kelli, with the NIKTT and Compass. They were some of the early times of that. And then there's Nari and Roxanne and I talking on our Australian Broadcast Corporation. That's not right. Our radio network, national network, talking about the community consultations and ensuring information got out there. And Nari and Darwin being a crocodile wrestler. So that was great. This is the different forms of journey mapping. So Inna is a really world-renowned artist. She was painting her journeys in a range of different ways so that she could share her experiences with many different people. And then on the right, Rani Lester, who's another Action team member with lived experience of kidney disease and transplantation, is working as a peer navigator, and you'll be talking more about that, Kelli. And she's been doing mapping using sand trays, and this was at Port Augusta working with dialysis patients, and Rani's given us permission to share the picture of her journey. This was her journey coming through. The other thing we've been doing with the journeys that we've mapped is comparing them. So community members helped to form what were the priorities and what needed to be in the Indigenous guidelines for kidney care. So now we can map journeys, and we've got something to measure them against as well. So we can measure, are these things being addressed within the care that's being provided? Where are the gaps? What do we still need to be doing? As well as using the levers of our national safety, quality, health standards. So they're the ones that all hospitals and health services need to show that they are meeting for accreditation. In particular, we've got three main standards about partnering with consumers, about providing comprehensive care, and communicating for safety. So we're very much linking in with national levers. Then with cultural safety, we were also involved in writing a cultural bias report, which is basically lifting the lid off of racism in healthcare. But at the time, we weren't able to use that language. I think a lot has probably changed since then. I think we're able to use more blunt language than we were at the time. It was a step forward, so we were also involved in that, and that might be something you probably talk about as well. The embedding of cultural safety into the national clinical guidelines, it was one of the first points that's there. Once we got to the guidelines, you'll see the first two recommendations are addressing institutional racism and cultural safety. So we're able to keep pushing. So that's been very effective. There's also we've got one of our team members, Melissa, is doing her PhD, and she's really looking at the emergence of cultural safety in kidney care in Australia, and then also looking at it internationally. She's starting a scoping review. And at a local level, there's a decolonising course. Do you get to talk about that in your talk?
No.
Do you want to mention it now? Because it's something you're involved in.
Yeah, it's actually happening at the Royal Adelaide Hospital. Myself and another Irish nurse are delivering decolonising practices in clinical spaces to over 250 CNART staff in the renal sector in South Australia, and bringing them on a journey of truth and really giving them tools and practicalities they can use on the ward to engage with our people safely.
Yeah, thank you. But some of the work that, you know, we're doing this work together. We've been working with people, we're working with healthcare providers, but also the decision makers. So in response to Nari and Ina's concerns and a lot of other people's concerns, what was coming out of the journey mapping, there's a place called Gangawadli that is Aboriginal hostel where people can come and stay. So people coming from rural and remote will come and stay at the Aboriginal hostel. And there's a few other hostels around the area as well. Well, one of the issues is that people would come down from rural and remote areas, and as also I've heard stories in Canada, and I'm not sure what it's like in New Zealand, but, you know, it's very difficult for people to navigate the city health systems, and there's so much going on, and people are disconnected from family and culture, and all those things Craig was talking about that keep people strong and really feeling, you know, often unwell on top of all of that, because it's kidney disease and often another chronic condition as well. So there was a real concern within the local health service that a lot of people were missing dialysis, and it was leading to emergency admissions. So the AKction team got together and, you know, with the priorities from community, working with the health service, and said, okay, can we take dialysis to where people are staying? So people don't have to have that transport nightmare. Let's put some dialysis machines in the hostel. So that's what has been trialled. It's been a successful pilot. We believe this is an Australian first. It's not happened anywhere else. So we were involved in helping support that process. It's a real collaboration with the health service and also with SAMRI, another research institute. And then also involved in the evaluation of effectiveness. And I think you mentioned this as well. No, but
we did start with 2 chairs and we're now up to 3, and it's a part of our South Australian renal strategy to increase it to 6.
Yeah, and that might involve building another building.
A whole new building, yep.
And the practicalities of that is if it's on one side, it's, you know, state held, you know, in the colonisation way, the state government has hold of that one and the federal government have hold on the land on the other side. So I think there's a bit of discussion about How's that?
It's on Ghana, we
Well, it
take a
is.
lot.
Well, that would be good. So there's all of those. Yes, I was being careful how I said that because we know that it's all Ghana land. Yeah. Then the other thing that comes up a lot in the transplant journey is the difficulty in accessing oral health care. That often and repeatedly people will say, I had all my workup, but I just couldn't get dental care. And dental is not included in our public health funded activities in Australia. They just didn't add dental to Medicare. And so it's a real problem and it's really expensive. So we've looked at multiple ways we could do things. And one thing we're currently doing is working with oral hygienist students. So they work at a vocational training centre, or they study there. And we've started doing clinical placements at Gangawadli. So you can see there in the picture in the middle, there's the students visiting someone while they're on dialysis and starting to do that early assessment. And in the picture down the bottom, there's Margie with the sort of curly blonde hair in the middle there. Margie is a little powerhouse, and she is well networked, and she's systematically working her way through to actually getting an on-site dental clinic there. So we're working towards that. The other part of this is that you can see Nari there, and now Jared's involved in this. We go into TAFE and we help run cultural safety sessions for the staff and students so that we can ensure when the students come on clinical placement that they've got their head around things and they can be more culturally safe in the interactions. We talk about cultural safety and clinical yarning. And Wade Allen, who runs the hostel, he comes in and talks as well and shares stories from, so students get an understanding of the impacts of colonisation as well and the importance of cultural safety. So that's good. The other thing we do, we go out to the regional centres. So the AKction team went over to Ceduna, which is
9 hours drive, I reckon.
9 hours drive from Adelaide out west. And so we are setting up there. We've got Billy the Kidney with us there, who was actually part of the Aboriginal Health Service. I think he was one of the board members of the local Aboriginal Health Service in there under Billy. And this was a forum we did where community members came in. We worked with the local health service. Sam, the nephrologist, came and we were able to meet community members. There was some early screening. There was referral for early detection and lots of stories were shared. So that was really great. And having people with lived experience sharing the stories was so important. We had written up the journey maps and that up on the wall. The other thing we've done is teamed up with medical nursing and allied health students who go to Yellata and they work with the primary school. So Yellata is another 2 hours past Ceduna. It's a remote Aboriginal community. And the students have set up, they link with the primary school and they go there and do a kidney festival. And so now we've teamed up. So that's the dialysis truck that has 3 dialysis chairs on there. So community members can come home, visit family at the same time that the festival's on. Sam's been working with the remote clinic and the nursing staff to identify who's at risk of kidney disease, who needs to see her immediately or at the next clinic she's doing in the regional town. So we've been pulling together a range of different activities there. Do you want to add on that one? No?
No.
And we also included the foot care team. They came as well, and the flying doctors and a whole heap of different people all come together. So yeah, now we've got the video. So I think this is where I flick back to you and you're able to do that. Beautiful.
This is our journey. Walk with us. Can you hear us?
This is our journey. Walk with us.
This is our journey. Walk with us. Can you hear us?
Family, my kids, my grandkids all keep me going.
My music keeps me motivated and keeps me at peace.
My family, country and culture, part of my care.
When you sit down and have a yarn with me, it means you can understand my pathway and my journey, and it helps me to stay strong and healthy.
We live with this disease forever. We need support, care and understanding.
Accommodate for everyone because we all can't walk.
My family, my culture, my country are part of my care.
We always set aside and watch the stars.
Train our people to care our way.
Beautiful stars.
Dialysis is my second home now. Help me feel safe.
And I miss the stars.
Being on country, being treated our way with our families around us.
It means I can hear you and you can hear me.
We notice the lights, sound and smells in the facility. Sometimes we need the lights turned down.
Help stop our young ones following us, getting onto the machines.
These are our stories. Walk with us.
Walk with us.
Walk with us.
Walk with us.
Walk with us. This is forever.
Thank you. I probably could have explained a bit more as we ran in, but as you can see, this was AKction coming together with the CARI guidelines and community members saying, we can explain why this is important. And it just cuts to the chase, doesn't it? Yeah, it's very powerful. Yeah. And then this is just my last slide. We the AKction team is actually quite huge. So we have the reference team members that have been with us and are still with us. We have a range of chief and associate investigators. A lot of the nephrologists who are working with us in AKction 1, we asked if they could step into a support role for AKction 2, which they did, which enabled community voice and the lived experience of kidney warriors to be strong. With the support around it. Then we have the project team, those who are in the office doing the work, and lots of different collaborations. We're also working a lot with PhD, masters and honours students. So helping to get them, the workforce skilled up a bit more, as well as doing some really important research. All of the research projects follow the priorities set by community. So people come in, they meet the reference team, they hear what the priorities are, and then we work out together how that can be crafted into a relevant research project for the students. So yeah, and that's it. That's us for AKction. So I'll stop sharing.
Awesome. Thanks so much for sharing about AKction. And then I think you're going to move on next to NIKTT.
Yeah, sure. So I'll move on to Kelli.
Okay.
Now you're next. I'll just organise myself my end. Now, have I stopped sharing? I have, haven't I? Yes, good. I've just got to get nicked up. Just bear with us a moment.
And I just want to add that our elder is here, Terry Gardner.
Oh,
And Terry, I apologize for not getting you anyway, for us having trouble linking you in. So Terry's actually in northern Saskatchewan right now, so she's calling in. So I just wanted to acknowledge that Terry's here, and Terry, at the end, it would be wonderful if you could say a few words before we leave.
Do that now, or
Yeah.
do that now.
Maybe
Hi
now. Everyone. Yes.
Sorry,
Hi everyone. Yes,
Yeah, go ahead, Terry.
Yeah. Hi. I said hi everyone. Sorry I was so late. But I will. I will have an opportunity in the end.
Instead of the end, Terry, would you like to take the opportunity now? We can wait.
Is that all right with everyone?
Yeah, absolutely.
Oh, okay. Okay. My name is Terry Hansen Gardner. Did somebody introduce me, Caroline, what I do up north?
No, not yet. So if you could do that, that would be wonderful.
Okay. Yeah, I'm a cancer survivor. 2011, I was diagnosed with cancer. And at that time, that's where I saw the challenges our people were facing. And a lot of our people in northern Saskatchewan, we're in a remote community. They don't speak English, so it's really hard for them to understand. And the financial cost, I still see some people hitchhiking to go for chemo, which is unacceptable. So after I got better in 2014, I make it my mission to help people wherever I can. I go wherever I'm invited. Sometimes in the summertime, I talk to 4,000 people. We have a Northern Health Education bus, which is the other part of my life is with Saskatchewan Cancer Agency. They're very supportive. And then, of course, SaskNear has always been there for me. And I'm very busy. I have other stuff that I help out wherever I can because our people are really suffering in the north. And what we're trying, Caroline, Dr. Tate is trying to do is so important. That's such an important subject that we must all work together. And in the end, if you want me to, I can pray in my language, but I won't hold you up any longer. Inigi, thank you.
Thanks, Terry.
Thank you. AKction screen, and it should be this one. I talked to the computer in my notes. Yeah, we'll see if we can get the notes up. I'm just seeing if I can get the notes up as well. 1 minute.
I can see your presentation up here now.
Yeah. So that's changed that now, hasn't it? Can you see the full screen or the parts or the PowerPoint slides?
Yeah, we can see the PowerPoint.
Yeah, okay, sure. So I'm trying to just see if I can give Kelly her notes. Bear with us for 1 minute while we do and I've got 3 screens going.
And
my mouse. Yeah. There's my mouse. Mouse. Oh. Sorry.
Janet and Kelly, would you like me to share your PowerPoint on your behalf? And you just say next when you would like it? Yes, okay, perfect.
Yeah, do that. That'll be good.
And so then we can just go to notes that way.
Yeah, do that. Okay, good. So I'll just stop sharing. Oh, you've got it? Good. Beautiful. Okay, good.
So if we could go to the next screen. I'd like to acknowledge the traditional custodians of my elders that have been, are and will be. I'm on the land today of unceded and ancestral nation of Kaurna people from the plains of Tardunyanga, Adelaide, the Red Kangaroo in South Australia. We stand on your shoulders and continue to pave the way for many generations to come. I pay respects to our spiritual and physical connections to Mother Earth, seas, skies and waterways, flora and fauna, where our cultural practices are strong and thriving today and always. Our sovereignty has never been ceded. I also give my love and respect to other First Nations brothers and sisters from your respective countries and territories who are present with us today. In solidarity, I stand with you all. I'd also like to let everyone know that there are images of loved ones that I'm going to be showing today, but we do have permission from their families as also themselves. But I always take a moment of silence in honouring our kidney warriors that have passed and that we're going to continue on with their legacy. So if we could just bow our heads and give some silence, please. Thank you. Next slide, please. Nanui Michi Kelly Owen, Napi Lewin Pombrook, Napi Naturcho Tardunyanga, Namawi Ninkui Turna Pola, Asham, Jarian, Isaiah, Takari and Karani, Mutha Kuku Kuku, Jarian Jr., Osha, Daniel, and Merwada. Namawi Pakunu, Garna Naranga, Mutha Naranjeri, Anononi. My name is Kelli Owen. I live in Murray Bridge, but my birthplace is Adelaide. I'm a mum to 5 children, Asham, Jarian, Isaiah, Takari, and Karani, and a mother or a nana to 4, Jarian Jr., Osha, Daniel, and Merwada. My grandfather is Garna and Naranga, and my nana is Naranjeri. So I am a Garna, Naranga, and Naranjeri sovereign woman, and we'll practice that together, Craig, next time we're face to face. I was diagnosed at 19 with chronic kidney disease. I had a kidney biopsy at 30, and I was already at stage 3B. So I moved home to South Australia to be on country and closer to my family and the support services that I was going to need to start the dialysis and kidney journey. I was 41 then. So I've used both PD and hemo. I worked full-time teaching, travelling off country with my 2 youngest in tow to receive dialysis treatment at the Royal Adelaide Hospital. It's about an hour and a half away from where I live, until a chair was available for me like 5 minutes down the road. I was blessed with a transplant on the 26th of May, and nationally that's our sorry day here in Australia, but it's also my thank you day. So I'm the first in my family to be on a dialysis machine and to receive a deceased donor organ. I do not have diabetes. I have Allport syndrome. And I'm also a CI of AKction, which we just heard about. And I'm also the CIA of Compass, which we'll hear about in my next presentation. I work at the Royal Adelaide Hospital, and I sit on the advisory board for the federal government's Organ Tissue Authority. So I'm here today to speak about NIKTT, the National Indigenous Kidney Transplantations Taskforce. So let's talk about why NIKTT was started. Thank you. So kidney disease is really serious and increasing health problem here amongst Aboriginal and Torres Strait Islander people. Our people are more likely to be experiencing kidney failure compared to other Australians. We're diagnosed at a much earlier age, and we have higher prevalence than with other health conditions. Despite this, Aboriginal and Torres Strait Islander people are 4 times less likely to receive a transplant when we need it. The National Indigenous Kidney Transplantation was established in 2019 to improve equity and access to post-transplant outcomes, kidney transplantations for all Aboriginal and Torres Strait Islander people around our country. So we had 4 main objectives, and that was to establish the task force. We needed to also get Indigenous reference groups up and running and to form a national panel. We then needed to evaluate a cultural bias initiative with renal settings around Australia, which Janet touched on, and I'll go in a little bit deeper. We also had to look at enhancing our data collection that was happening to improve the understandings of these waitlisting barriers that are happening in our country. A part of it was also piloting equity and access sponsorships around the country to improve the waitlisting for our people. So based on the available published material and grey literature, the Cultural Bias Report identified 14 individual recommendations to address, I'm going to stop saying cultural bias, racism within the Renal Health Service, the national organisation and funding bodies. So this report really only identified 2 peer publications from the Australian renal setting, which address our specific research question, along with a few other publications from healthcare fields, such as the maternal and oncology areas. We can be here for days talking about the cultural bias report. Sorry, yep, if we're on the next page, yep. Within our health system, due to our time constraints at the moment, but I'm going to need to move on. But I'd like to suggest that you visit our NIKTT website and take some more time to read it. We do have a policy overview that was presented to our ministers. Instead of, I think it was about 150 pages in the report, there's a better overview that you can see. Okay, so if we could just go back to the enhanced data collection. Thank you. Data is not my domain. That was Professor Stephen McDonald, and he led this project with the assistance of forming a data working group within the task force. So really what he was doing was looking at 26 different dialysis units across Australia that were involved, and we're actually funded to collect this data specifically to look at what are the waitlisting barriers. So as you can see here by the findings, they really range from cancer, cardiovascular, high BMIs or obesity. But there is much more research that needs to be done in those areas to really define what are these other reasons. Again, if we could visit the website, www.NIKTT.com.au, this report is there for your viewing and use and referral. I was actually employed to travel the country and hold space for brothers and sisters to tell me their journey in their area, what was happening for them. And then I would bring that information back to the task force and share what's actually happening on real ground, on the ground with lived experience people right now. So of the 26 members in the task force, there were different working groups. I was actually co-chairing with Associate Professor Shilpa Jezadiasan, the Community Engagement Working Group. So our priority was to establish 5 Indigenous reference groups in South Australia, Western Australia, New South Wales and Queensland. COVID hit. I could not get into New South Wales, was struggling to get back to Western Australia. Also the lack of funding happening from within the hospital for a First Nations person to be driving these projects, it just wasn't forthcoming. So we did have meetings that happened, but I was lucky that I was leading here in Adelaide, the Royal Adelaide one, which covered Northern Territory, South Australia, a little bit of New South Wales and a little bit of Victoria. And we did get the national panel up and running with 175 members across Australia that wanted their voices elevated, wanted their concerns raised, and wanted to have some action and a working plan of how we were going to address them. A part of our area was also sponsorship projects. So these were held right across the country. There were 8, and they really focused on outreach clinics, strengthening the workforce, and educational sessions that were really important for patient navigators to be helping people that were just starting the journey. I went on a lot of these outreach clinics that were happening across Australia with different teams. We're talking about having nephrologists, the surgeons, social workers, pharmacologists. Everybody was in this team, was travelling to remote areas on country, holding workshops with community people. And it was a real, there were unintentional lessons being learned here, this two-way sharing that was happening. And they need to continue. This needs to be sustainable from a hospital level. The amount of people that were actually able to be put on the wait list due to these outreach clinics was doubling. In terms of the costs involved, normally individuals and families would be, provided transport to go down to their metro capital area where these transplant clinics are. So there was not only cost savings for the hospital, but a lot of cultural learning for these teams that were going and meeting not only the patients, but their families and understanding the country in which they were coming from. So again, with the findings of our outreach clinics, 37 patients were referred and 28 attended these clinics to get onto the wait list. 2 of them were not suitable, but 26 proceeded with the workup to get onto the transplant list. And we had 13 out of 28 waitlisted by the end of December 21, and 12 out of 28 actually received a transplant. Our patient navigators, again, 29 patient navigators were available for the assessment. By the end of the project, there was 11 suitable for workup, 12 referred for workup, 5 weren't suitable, but 1 was on the active transplant list. There was also the educational sessions that were happening and workshops. There was qualitative findings from the Princess Alexandra Hospital in Queensland that the educational sessions on country were very well received. And this is what we were talking about, that two-way sharing. And being based off country was just, you had to be there. It's, you know, really our ancestors were with us when we were on country. It was amazing. So to have 2 patients transplanted and 4 more on the active list, these are our numbers growing that weren't there prior to Nick coming in and being a bridge between these services. We also actually got together when we're traveling, you know, what do you want? What do we need to be doing here our way? They wanted a national gathering. So we actually had 30 patients from around Australia come as a collective, and we actually did a national position statement. We had guiding principles of us all coming together, but we came together with the clinicians from around Australia. It was a black space where our voices were heard and we were leading these discussions, but we also were asking for the input of the clinicians. It was over 2 days here in Taranyaga, and move around again, thank you. But it was really a way in which we were able to endorse the recommendations that were being made from the racism report and able to really come together to design what we wanted to do in the future. Here's an amazing photo of the time a lot of the people, our consumers, have passed since this photo was taken, but to capture their stories and what they wanted to happen in the future just gives that more fire in the belly that we are going to do this. But some of the things from the position statement that you can read about on our website was being able to establish a national body to represent Aboriginal and Torres Strait Islander people that live with kidney disease and transplantation, which will oversee the support networks, resources, reporting, monitoring, and accountability. 2 was that we needed ongoing development of programs to facilitate better access to transplantation, with particular focus on improving the health of our people with CKD so that they can be waitlisted. We needed monitoring, recording, and reporting through an annual source card on improvements in the workforce, program delivery, and transplant waitlisting to achieve transplantation. We're working with workforce partners to grow an experienced and culturally safe and resourced Aboriginal and Torres Strait Islander regional workforce across all levels of transplant access and post-transplant care. We need to be promoting the transparency and accountability of funding for kidney health services so that we know how decisions are made and by whom and what is actually being achieved, but also enabling awareness raising and capabilities of national networks through sustaining a general gathering meeting is exactly what everyone was calling for. So our recommendations so far is to utilise the models of care that work. Again, our Indigenous reference groups, patient navigators, and outreach clinics, to ensure our governance and oversight for cultural safety. So again, Aboriginal health and Aboriginal hands. Create an integrated whole of life system. You know, treating the kidney problems before they start. Where are these prevention models happening? Where's the education, you know, so that we can ensure that the care is continuous throughout diagnosis to post-transplant. The biggest voice that we heard is that we need a national peak body. So the position statement that came out of that gathering, we were able to use as leverage to lobby and advocate at the federal government. There's, again, have a look on the website for the position statement of everything else that was listed, but being able to use that work as a collective voice, that's exactly what we've been doing. We have been attending and lobbying ministers in Canberra. We are talking about what we need. We have been advocating that we need ongoing sustainable funding for this to happen. So here's a timeline and a summary of what I've just talked about, but where to next? We have bridging funding until the next federal budget is released to continue the work of the National Kidney Strategy. We're actually going to be a part of this National Kidney Strategy. So our goal is to have this national body for our people to address kidney advocacy, research, prevention, treatment, and transplantation and beyond. And that is the next stage of what's happening with NIKTT. There's a QR code on my next slide, as well as this one, looking at a supplement with 6 different articles that were in the Medical Journal of Australia, that if you'd like to read about our journey and what happened with NIKTT and where we're going, please go and have a look at them, have a read. But I'll just flick down to this one. Again, the QR code. And if there's any questions before I move on to the next topic about patient navigators, I'd love to hear.
For
That's
sure.
good.
I'll also ask people if they had any questions, they could type them in the chat box too, and I can circle back to them. But if you wanted to even share the last presentation you had for this time,
sure.
we're planning to go for break at about 20 minutes after. So
Okay.
you know, as much time as you want to take there, and then leave a few minutes there for questions at the end.
Wonderful.
Oh, open up the other one.
So while we were waiting, I will say, for this funding to come through for our national body, we've got on and kept working, and I've been doing Compass. So Compass is connecting our mob patient navigators to sustainable supports. Below is, I'm doing this presentation on behalf of everybody there. This is, again, collective work. Next slide, please. So what are patient navigators? Well, they give everyone the opportunity to have a support person with them throughout their journey. It's somebody who knows what it's like to sit in that dialysis chair. It's someone who's undergone all these tests for the workup to get on this transplant list. It's also someone that understands these complex systems that we have to navigate through ourselves. It's someone that has an established relationship with health professionals who make the decisions and know how to get things done. It's also someone who is accessible for the person in the journey, as well as their family and community. And most importantly, it's someone who'll have your back when things get really dark. And we do have dark days, and we need that extra support. Patient navigators are there. Next slide. Thank you. So where are these patient navigators? What's happening? So we have a whole heap based in the north of Australia, in the Darwin area. We also have in Central Australia, we have them there as well. These are our 4 sites. And then we actually have some in Port Augusta. And then we also have some in Adelaide. And Adelaide is the place where we have our transplantation. So everybody has to come from north and travel down to be here. Next slide, please. Sorry. Yeah, sorry, yeah, I didn't see it. Yeah. So what work has already been done, so we don't reinvent the wheel here? You know, the Panaku mob from up north and Purple House in the Northern Territory have been doing this work for 10 years, you know, and there's been a real dramatic increase of the numbers of people who are being worked up and listed for transplant. Most recently, yesterday, an assessment team went up to Darwin, and Professor Toby Coates texted me and let me know that 6 more people were on the wait list. It's like, yes, our people are getting on that list. Most recently, AKction. If it wasn't for AKction, I would not be in this role and what I'm doing. AKction brought me in when I hadn't met any other First Nations people in Australia. And it's become my family. It's a support family, you know, that's developed into another research project. But if it wasn't for AKction, I would still be teaching in a classroom. So again, you know, the other work that's been done, the On Track to Transplant team, they were in Port Augusta. They were one of our sponsorship programs that came out of NIKTT. So all of these people, all these organisations have somehow influenced Compass to get to where we are. Thank you. So I just want to give you some perspective of people that haven't been to Australia. 3,000 kilometres travel from Darwin up the top end where it's really hot and muggy, but beautiful rainstorm and, and thunderstorms, down to where we are, where the transplant clinic is. And, you know, you're talking about being off country, being away from family, being in another world because no one's speaking your language. You know, you're in a concrete city, hustle and bustle, and you feel very isolated and disconnected. So that distance that's put there is a massive barrier, you know, and being a totally new environment and, you know, are they really able to give true informed consent and understand what's happening to their body without interpreters from their community? And it's really scary. So as a Kaurna woman, I have a responsibility in my community to make sure that we protect and keep these people supported. And that couldn't be done without AKction and NIKTT and Compass happening, because I can't do it by myself. Thank you. So there's 4 teams that are involved in this project. Again, the top end, we have Punaku, Central Australia and Alice Springs, we have Purple House, and we have 2 patient navigators and a coordinator there. And then, you know, we cross these invisible lines that have been put there by the colonisers, and we step into South Australia, and we're coming home now to Port Augusta. And we have 3 navigators there, as well as Kylie Herman, who has been an amazing advocate in this space. And then we come home to my country in Kaurna Yata, Tadanyanga. And again, we're the only transplant unit that services all those areas, and they all fill into us, as well as a little bit of Mildura, which is part of Victoria, and a little bit of New South Wales, where we capture Broken Hill and Wilcannia people. Thank you. Here's a bit of overview of what I'm just talking about, what's happening here. And that's Compass. Our project builds on these existing models, patient navigator models in South Australia and the Territory, to validate findings and translate knowledge through Aboriginal and Torres Strait Islander-led research and governance. And this was going to be achieved through 2 project aims. One is co-building the coordinated network of patient navigators by strategically linking these existing groups and creating a new group in the key locations in South Australia and the Territory. The second one is embedding these into sustainable everyday health services by identifying these strengths and enablers that allow our patient navigators to improve the treatment journey of our people with kidney failure. Next, we value these differences that the programs bring. Punaku and Purple House services sit outside the health system and is community controlled, while Port Augusta, the On Track to Transplant team and the Royal Adelaide Hospital team is embedded within the mainstream health service. Both have advantages and disadvantages, but what we're interested in is how is the process of the peer navigation happening at each individual service site, and what supports are wrapped around the patient navigators and who's looking after them. Who also establishes and maintains these relationships with the mainstream clinical services? Who does the follow-up? And how do we build in flexibility and understanding into these, while maintaining accountability, into these high-level services? And how do we allow them time, space to breathe, reflect and debrief, recognising the trauma and the role that these navigators keep stepping into? Well, it's about time and space for change. So we make time for ceremony. We create an environment that builds cultural safety within the system, and it's a priority of our project. We're conscious about avoiding burnout and allowing time for these cultural commitments and responsibilities. Also for creating and maintaining these relationships. It's not just stepping in, hello, I'm doing this and walking away. It's ongoing, and that's that respect. We understand, you know, there's constraints of the system that we have to work in, but we also have to help our mob understand and work within those constraints that are stepping into this system as well. But most essentially, it's about the success to ensure that there's always sufficient time and trusted support around that navigator. So how are we doing this? Well, we're working really hard on increasing the capacity within the group. Our relationships are being formed between community, clinical, and the research agencies. And this has meant ongoing, often uncomfortable, sorry, I've just seen what's happened to that picture. Often uncomfortable conversations about people's decolonising journeys for the non-Indigenous researchers and clinicians. It means understanding the rules of the system to create this flexibility within the project and doing it black way in a white system. Most importantly, it means ensuring that the time, the space, and the money to share everything back to not only our chief investigators, but our communities that we are visiting and working in. So here's a timeline of what's been happening. So we're standing on the shoulders of everyone that came before us, like Purple House and NIKTT. So Compass has established the 2 peer navigator sites in Alice and Adelaide, and we're establishing the benefits of the programs within the health journey mapping. We will be yarning up with clinicians and the health service executives to embed these programs into mainstream services. So we need you to really watch this space next year and beyond. So where to from here? What are our next steps? Well, we've got to get SHAPE done. First, we need to start with kidney journey mapping. So Janet did mention kidney journey mapping. Again, we're using, Ina Winchie's artwork, the CARI guidelines, and please approach us, either of us, after the session if you want more information on this. But again, it uses the methodologies of the Diri and yarning to deeply understand health journeys and identify the strengths and gaps in care. We take many stages, which can take many shapes and forms, but this picture is to map our elders' kidney journey, where she describes the white circles in the centre representing all the Aboriginal kidney patients coming together to have a yarn about the kidney health with doctors and nurses, talking about the plans for the future and sharing what they want to see happening to improve the kidney health of their people. The outside circles represent patients in dialysis with cleaning their bodies to keep them well. They're 2 footpaths that represent the journey of kidney patients. The wildflowers, the grasses, and they're represented by purple, white, black, orange, and green dots. So we're going to map these journeys of patients before and after the interactions with the patient navigators, which will help us to understand the enablers of the program and what barriers that we need to overcome. The journeys will be synthesised and cross-referenced against the CARI guidelines to understand the degree of a gold standard clinically and culturally safe models of care, so we can further identify areas of need and areas of celebration. Yarning circles. So we bring together patient navigators, clinicians, and health service executives to collaborate, and we create Gunma. Gunma is a Yolngu philosophy whereby the water, which is from the sea, are the peer navigators, and it meets the water from the land, the stuffy old white fellas, to create new knowledge. So this new knowledge is our case to identify the barriers and the strategies in the environment of mutual learning and quality improvement to deliver sustainable, coordinated programs long-term, embedded into a routine clinical care. We're going to do this 3 times at 4 different sites with 3 different cohorts to deeply understand what it takes to build this model into mainstream health services. And then we're going to be looking at the knowledge translation. What does that mean? We are going to be continuously taking this knowledge back to community, getting our ideas and assumptions and messages checked, and then report back what progress has been made. This will be through a formal knowledge translation process, but also informal processes by the patient navigators who of course are already deeply embedded into the program. So where to from here? Finally, we will continue to advocate for our people, including at a national level, where we'll work towards establishing a national body for First Nations kidney warriors to guide and inform the work in this space that allow us to roll out a framework we will develop across multiple sites for chronic diseases embedded into patient navigators as an essential part of clinical services to ensure long-term sustainability. So where are we now? Here's a sneak peek of our website to assist our patient navigators. You know, everything from being able to share resources, reminders of project updates and meetings that we have, being able to contact anybody within the project team to help them if they're stuck along the way. The next one is an actual portal for our patient navigators to be able to get hold of resources in real time, the information that they need, minutes, and even the bi-monthly meetings, having that information on hand when they need it. Also sharing of new sites of how patient navigators are doing it from established sites, you know, and it all leads back to better care for our people. This project actually finishes up in June 2025. This is my first day back from leave, but I actually thought that we would have our patient navigators happening in the Royal Adelaide Hospital today. I've just been told that HR are still working through the red tape and processes for contracts. When I finish this presentation, I'm going to visit HR to get it going. But we have 12 months of data collection from patient navigators with this, you know, by June next year to be able to report back. So thank you for listening to me.
Wow. Thank you so much for sharing. That was a lot of presentation for us, and glad you have some water nearby there to take a sip. That was a lot of information to share, and it's good to see you, Janet and Kelly, again. Just to let everybody know, I had the pleasure of meeting them both in person when they were here on separate occasions in Vancouver, and so it's always a pleasure to see you again and get a bit more update on the work that you're doing. And so that's been really great to hear of the progress. I noticed in much of your work as well that there is so much artwork that's involved in your work, and, you know, a lot of beautiful designs for each of the logos of AKction and NIKTT and Compass. And I guess my question was, how do you find the use of art or the use of Indigenous ways of knowing is benefiting the work that you're doing and showing you know, the ways that we bring our culture into the space?
Craig, that's our way of communicating. Not the only way, but a massive way that we've used, being able to retell our stories and using symbolic representation in this new era of telling what's happening, you know, with not only ourselves, but with community. I think having an opportunity to be able to present our artwork that is so rich in meaning and history and the future, where we want to be, you know, for our future generations. It's a really proud moment, that being able to have Inawinchi's artwork, or to have Kiki's artwork for NIKTT. And we actually had young Isaac did Compass, which were the 4 kidneys representing the 4 sites and the journeys and interviews that we've been having along the way. So it's a reminder of where we've been as well.
And I think in Port Augusta, there's, you know, Inawinchi's old dialysis machine that she painted up, and prior to that, there was another local woman who also, can't think of her name, another Lipsy's one, and I think it's actually a little bit of I'm not going to say this quite right. Kelly might help me out, but there's like an ownership and a decolonisation of this system that you can paint over and tell your story. And with Lipsy's machine, it sits in, they take it to various places, and community can see the dialysis machine and they can see Lipsy's story on the dialysis machine. And it just tells the story, and it brings it up in a different way and within the context of Lipsy's life. And there's something very powerful about that.
It is. It evokes a lot of emotion when you're looking at it and being retold, you know, someone else's journey through the kidney disease. It's emotional, you know. Yeah.
And they're funny too, it triggers people to say, can I have my checkup? Because it's obvious that it's linked to, if, you know, here's the journey and here's the kidney machine. So, yeah.
Fantastic.
That's
I know
nursing.
we're getting close to the break here, but I saw Caroline, you had your hand up. Did you want to jump in with a quick question?
Yeah, thank you so much. I was taking notes, and I'm gonna go listen to the presentation again. But one thing that struck me that's different than our conversation earlier today is that one of the things in Canada is that we have, you know, federal and provincial jurisdictions. We have First Nations, Métis, Inuit, which have different relationships with the government. We have expectations of our Indigenous leaders, right? So our Indigenous leaders and our Indigenous health leaders. And funding flows oftentimes for like project money. So money flows through provincial health bodies. It flows a bit through what we call Health Canada at the federal level. And then it flows through some of our Indigenous political organizations. And so whenever we're doing work in this area, there's these considerations about all these different stakeholders. And in some ways, I guess I would describe, and Veronica McKinney is on the line, Dr. McKinney, who works for Northern Medical Services. We're in a messy situation of jurisdictions and expectations that relate to resources. And so in some ways, I think, and Veronica, you might want to chime in, I feel like we have clay feet in this country. And Chief Philip from the BC Chiefs talked about this today a little bit about, you know, this organ donation and transplantation does not get as much attention. It's partly because it's not funded in ways that other issues, as he pointed out, like cancer and HIV and addictions, it's not funded in the same way. And so even in terms of our leadership, they're not looking at it and saying, okay, there's resources and there's money there, so we want to be in the conversation. It's like, it's just buried in all of this other stuff. So I noticed today that you didn't make reference to Indigenous leadership, that it's more from a grassroots, patient-centered, patient. So how does that work exactly? And I don't know, Veronica, before I turn it over, do you want to say anything about the messiness that we live with?
Sure, yeah. So I'll just see if I can turn on my camera. Sorry, I was driving, so I'm just pulling over here. But yeah, that you're absolutely right. The jurisdictional issues consume so much time because you're trying to you know, share information and spread it across, you know, all these different jurisdictions and such, and not only with the individuals, and really trying to elevate the voice of the people, really, at multiple places. And it takes sometimes years and years before you actually get everybody sort of on the same page in terms of information sharing and trying to realize like this is important, let alone then trying to get money or finances to try to actually address these things. And it is really exhausting and tiring. It's really hard and complicated. Many people, even within the system, don't really understand the layers that we're going through. And a lot of it's bureaucracy in many ways. But yeah, it's very difficult to navigate. In fact, a lot of my job is just literally running all over the place, trying to, I call it being like the cross rungs, because there's so many systems running in parallel, but nobody's talking to each other. So, you know, it's a lot of wasted time and energy, I would say, on those pieces for sure, instead of actually just addressing the issue.
Yeah. Well, I agree, Veronica. That's definitely happens in our country. We have federal and we have state and then we have local. But Carolyn, is exactly what we're doing. We're coming from a grassroots level here in South Australia, and we've gone up that way. We've actually had health professionals amazing Professor Jackie Hughes is our only Torres Strait Islander nephrologist in Australia, actually meet at a federal level and advocate there. They knew within the health system that they weren't getting it right. And we know as patients, they're not getting it right. We had to work together, and we had these doors being opened for us for the first time to be able to go straight to federal. We will loop back to AKction and Aboriginal organisations, and we have to work with them because we're in an acute setting within hospitals, but we need that follow through coming back into communities. But what I found also with the Close the Gap report here in Australia, it doesn't address kidneys, it addresses other chronic diseases. It doesn't look specifically at kidney. Our voices weren't getting heard. We're living these journeys and we have a voice. So let's actually get up and do something, and that's what we add to that journey.
Yeah, I think the other thing that happens alongside this interweaves is the work of people like Stephen McDonald, who is, heads up ANSTAR, the Australian New Zealand data set that records everything around dialysis and transplant. And also, is involved with determining where dialysis machines go. And so we've also got people who've done a lot of really solid research, who have good standing within the nephrology and the community, who have levers. So I think there's the community, there's a really important work that Jackie Hughes have done.
Yep.
And then there's also quite a few influential nephrologists and renal nurses that I see as well that are supporting. I think the other thing that made a real difference is everyone came together and they worked. There's some places within Australia where that works better than other places, and we're just lucky that at the moment it's like that sweet spot where communities coming together with researchers, coming together with nephrologists, that there is some interest and the doors are open in Parliament in ways that sometimes they're not. The AKction project is mainstream money. We just went for a National Health and Medical Research grant. It's not Indigenous money. We just made it, and we grabbed mainstream money and embedded an Indigenous program because we just needed to drag it in.
And that's the Compass program as well, mainstream money, while we're waiting for federal funds that are coming from health mainstream funding, not specifically Indigenous funding.
Yeah, so we grabbed what was available and tweaked it.
Because there's nobody else in this area addressing the needs of First Nations people in kidney health.
Love your hand signals there, Curtis.
Yeah, you don't need words, you just need some good actions that everybody knows to understand that you're in solidarity with the messages being shared. So I know that we're just heading for a break now, so